So if I will lead on to just the case today. So this is CP. He's a 70-year-old male. And he was referred by his general practitioner to the COPD specialist centre that we have here in Oxford with the following referral letter. Dear COPD clinic specialist, please can you see this delightful, usually sprightly man who has been suffering with worsening breathlessness over the last 6 months. He's an ex-smoker, having stopped smoking following a diagnosis of angina a few years ago. We are unable to do spirometry in the clinic and wonder whether his symptoms are because of COPD. He has been tried on salbutamol to no effect. So this is a very common referral to our COPD clinic practice, and we can certainly discuss some of the pertinent points of the referral later on. So in our seeing this patient from a clinic point of view, his presenting and history of presenting complaint are as follows. So Mr. CP is an ex-smoker. He started smoking at the age of 16 and stopped 50 years later at the age of 66. He smoked on average 15 cigarettes per day, and he's been a clerical worker for most of his working life. He tells me that he has an exercise tolerance of approximately 100 meters, and the decline has been longer than 6 months when further interrogating him. He tells me that he's been slowing down for a few years, and he attributed his slowing down just to getting older. He reports little sputum production, and he tells me that his symptoms of breathlessness particularly are worse in the morning and on exertion, such as walking over 100 meters or a flight of stairs. He denies any history of chest pain, and when asked if he's had any exacerbations, he looks perplexed by the question, but does then, on further inquiry, says that he has bronchitic episodes every year, particularly during the winter for the last 4 years. He was diagnosed with angina at the age of 64, as I said, having gone to see his GP and then being referred to the cardiologist. There's nil else on his past medical history, and he currently is prescribed aspirin, simvastatin, bisoprolol and salbutamol as and when required by his GP. He does not report he's found much benefit with the salbutamol inhaler since going to see his GP with his symptoms of breathlessness. So these were the investigations, and I've just briefly added them here. As you can see on the left-hand slide is a CT image of a slice from his CT, which I think we would all agree conclusively shows emphysema, which appears to be moderate to severe in aspect on that one slice. His lung function test demonstrated an FEV1 of 1.5 litres, which was 49% predicted for his height and age, with an FVC of 3 litres, giving him an FEV1 FVC ratio of 50%, implying that he is indeed obstructive. He has significant gas trapping with a residual volume of 200%, and his DLCO is reduced to 44%. We did perform bronchodilator reversibility, but there was no indication of bronchodilator reversibility in his testing. Blood tests as a screen included an alpha-1 antitrypsin, which was normal. His hemoglobin was also normal. Eosinophils were on the higher side at 430 cells per microliter, and his vitamin D, not surprisingly, was low in that aspect.
So thanks, Mona. If we can just hold here for a moment, you know, your first slide said that this patient was unable to do a spirometry test on the referral note. So I just want to know what that's all about, because spirometry is such a basic test in COPD, and we know there is underuse of spirometry, and unlike an ECG or an ultrasound, which gets so easily done, the spirometry is a challenge. And is it, you think, because of, you know, lack of technician training, or is it that doctors just don't refer for it when they find the patient can't do it very easily?
Yeah, so I think it's a really important question, and I think it's a multitude of problems that make up the overall effect of a lack of spirometry being done in primary care, particularly in this country or even globally. So I completely agree that firstly, perhaps the staff are not trained appropriately to do the test, in order to be able to interpret the test. So that's the big challenge that we have in this country. Secondly, I think perhaps in respiratory medicine, we've perhaps disempowered ourselves to saying to primary care physicians that actually this is as important as an ECG, or as important as a chest x-ray, or as important as an echocardiogram. And we haven't made that impasse yet. And so therefore the importance of it, even as a screening, is perhaps far less observed. Finally, it is not surprising that some practices around my local area here in Oxfordshire just don't have access. They have not bought their own spirometer for the clinic nurse to do it in their clinical practice. It is just not done. So referrals like this are actually not that uncommon. For us, it's disappointing because, like you have just said, we would want.
And you also mentioned, Mona, that the note to you said that he tried salbutamol with no effect. And that also seems to be a little surprising in the sense that he's pretty far out with COPD now, and yet gets no relief with salbutamol. What was your thought on that?
Yeah, so I guess it's surprising to us as specialists, perhaps, but that is indeed what is suggested from guidance, from national guidance, and from global recommendations, that people are started on bronchodilators first. And indeed, it's not specified as to which bronchodilator should be started first. And we would all recognize that something like COPD, particularly to this effect, to this severity, is never going to really have any impact with a short-acting bronchodilator. So we would know it'd be the wrong thing, but it is very much a standard approach in the clinical treatment pathway in the community.
Sure. So basically, what you're implying, Mona, is that even when the disease is so far advanced, this is probably the maximum the patient lands up getting prescribed before he reaches the tertiary clinic.
Got it.
This is before they get that diagnosis, yes.
Sure. And I'll go back to that note because I know I'm constantly coming back to it. It's an interesting note. The diagnosis of angina was made 4 years ago. And I somehow see this as the heart always getting priority over the lung. And we've seen this happening, that patients perceive their cardiac condition as a much bigger priority than their pulmonary condition. And do you see this sort of tendency across the UK as well, where cardiology units far more aggressive than respiratory units? Or have you seen respiratory units which can be more aggressive than a cardiac unit? And I'd love to hear your thought on that.
Sadly, not is ultimately what I'm going to say, and that's a personal opinion as well. But you are absolutely right. The heart units seem to be more important than the lung units, and that's a good way of describing it. And I just wonder whether it's because the heart cardiologists and the heart units get a lot more funding. They get a lot more kind of empowerment. There's a lot more patient and clinician advocacy, as well as there's a lot more knowledge as to what to do in terms of treatment. So, we all know that time is muscle, for example, for acute myocardial infarcts. We've had several definitions of an acute myocardial infarct. Everything is improved upon iteratively. Unfortunately, with COPD, we are very limited by the blunt tools that we have for diagnosis, and I think for treatment too. So we've got a long way to catch up before the world accepts that the lung units are more important than the heart units.
Yes. Richard, you want to add to that? You've devoted a significant part of your life to COPD and the journal.
Yeah, I think Mona is absolutely correct about that. And Mona and I often speak about how cardiologists have a different attitude. Respiratory physicians often like to think and cogitate and be cautious and careful, even when we have medications which are not only effective, but also are extremely safe. Whereas cardiologists are often a lot more aggressive and will be prepared to take risk, it seems to take risk. And then the other thing I would certainly say, attitude-wise, is that a cardiologist will never, ever wait until the second heart attack to optimize their therapy. And I'm going to talk a little bit about therapy, but we wait. And we wait until they've had several infections and attacks. And actually, each of these infections in respiratory disease, each of these exacerbations of COPD has consequence. And we do not perceive it, I don't think.
Please continue, Mona, please.
So I guess following on from that case, you would all agree with me that the diagnosis is simple. We have a patient who has moderate to severe COPD. They have evidence of emphysema on their CT scan. They have a clinical history suggestive of, and they have diagnostic spirometry for chronic obstructive pulmonary disease. So yes, it's simple. However, the patient has several important questions. And this is something that all of us may encounter with patients that come to see us, particularly when they've been struggling and they may never have heard of COPD, or they may not know what their trajectory or likely history of the next few years would be with their diagnosis. So my patient CP has the following questions. Will the treatment you give me improve my health? And if so, by how much? Will I get worse? And how will you stop me from getting worse, doctor? And then finally, if I'd been diagnosed in my 40s, would I be this limited now?
Yeah, Mona, these are all phenomenal questions which we need to answer better and which I'd love to come to in some time. But I want to come back to a very fundamental question. And I want your thought on it, Mona, because a lot of physicians, my colleagues and across the world, get this one question from a patient, which is, what is COPD? And I know it's just 4 alphabets, but it's not that easy to actually explain it to a patient, and especially in many non-English speaking parts of the world. So how would you advise physicians to make this disease simple to understand, which is so important when you deliver the diagnosis?
Yeah, to the patient, I say that chronic obstructive pulmonary disease is a condition, unfortunately, that is likely as a consequence of the previous exposure he or she have had. And in his case, I would say it's smoking exposure. Right. I would also say that the problem, unfortunately, is irreversible at the moment. But treatments would aim to try and prevent or slow down the speed at which someone declines, such that I'm trying to normalize the speed of deterioration to just normal aging processes. And then I would lead on to say how the treatments would work, which would be about opening up the air tubes as much as possible, improving exercise and muscle as much as possible, in addition to then managing these acute crises episodes that they have and trying to prevent them as much as possible.
Yes. But I just tend to feel that this patient often gets challenged in understanding this. And, because they've often been prescribed at least maybe one inhaler, they confuse it with asthma, and they don't get the relief that an asthma patient gets with inhaled steroid. So is there a way to communicate this better to patients so that they understand the difference between COPD and asthma?
Yeah, I mean, the communication is really important, but I guess what we would be saying is the irreversibility aspect of it, where, we expect, it's ultimately it's expectation that the patient has and the expectation that the clinician has at the same time. Sure. I don't expect my patients to have no symptoms with 1, 2, or even 3 inhalers. I would try and maximize everything as much as possible, with the ultimate aim of then saying that the objective is not only for us to get the COPD managed by treating it, but also for the patient to be in control of the COPD, as
Sure.
opposed to the COPD being in control of the patient. So it's really about all of the other aspects of seeing and playing with the grandchildren, going out to the garden. All of these aspects I think are really important, and it's about understanding the expectations that a patient has.
That is so true. And I think we sometimes fail to understand what the patient's expectations are in a busy clinical practice. We also sometimes need to understand that what we want for the patient is different from what they want from us.
Absolutely. I hope Richard can answer the questions with his talk.
Okay, great. So these are all, Mona, great questions. Big challenges, I can tell you, even in tertiary care, and I'm sure we will cover this towards the end.